Good afternoon all. The topic of my study is a study of functional outcome of children who were screened for retinopathy of prematurity. One blind child is a tragedy, whereas a million blind children, statistic. So, retinopathy of prematurity is the main ocular problem of premature infants during their neonatal period. Retinopathy of prematurity is an incomplete vascularization of retina, which is mainly attributed to an oxygen-induced damage. While later in their life, strabismus, amblyopia, refractive errors, and visual impairment came into play. So the aim of my study was to determine the functional outcome of preterm infants based on their refractive status, fixation behavior, and also to analyze the risk factors for amblyopia. So it was a hospital-based cross-sectional analytical study done in children with 6 to 8 years of age who were born prematurely and who have undergone ROP screening during the year 2012 to 14. I did a sample random sampling, and the sample size was calculated statistically using the formula 3pq by d square derived from my parent study. So after receiving consent from the patients and also parents and taking assent from the children, I used a standardized performer to derive socio-demographic details and past treatment history. And then the best corrected visual acuity was measured with the help of Snellen's visual acuity chart, and a detailed ocular examination was done with slit lamp biomicroscopy and indirect ophthalmoscope. So children who were born at a gestational age less than 34 weeks and are all with birth weight lower than 1,750 grams, and those with no other systemic diseases, and those with a refractive media, clear refractive media, in whom retinoscope is feasible, and those with no eye diseases except for ROP was included in my study, whereas those with an incomplete information and non-cooperative children, and those with family history of high myopia, and those children who were diagnosed with stage 4 or 5 ROP were excluded. So I've studied visual acuity, cycloplegic refraction for assessing the refractive status, and amblyopia was diagnosed according to the criteria given by American Academy of Ophthalmologists, and also the fixation behavior was studied. So my results, out of my 61 children, 61 had no ROP, and 28% had type 1, 8% had type 2, and 3% had aggressive posterior ROP. Simple myopic astigmatism was found to be the major refractive error with 31.1%, followed by compound myopic astigmatism, myopia, and hypermetropia. Strabismus was found in, exotropia was found in 24.6% and ESO in 9.8%. 77% of them had amblyopia. And I also studied association between refractive error and amblyopia, and a statistically significant correlation should be made out between amblyopia and refractive error, whereas no such association could be found out between strabismus and amblyopia. Also, there was a statistically significant relation between the presence of ROP and refractive error. Also, association could be drawn out between the severity of ROP and refractive error. So, in my study, simple myopic astigmatism was found to be the major refractive error, and I could see that refractive error was the major risk factor for the development of amblyopia, and the risk of refractive error increased with the severity of ROP. A study by Hallstrom et al. Followed 248 infants for 3.5 years, and they also found an increased incidence of myopia, astigmatism, anisometropia, and strabismus. And according to a study by Wang et al., premature babies with or without ROP are susceptible to myopia and astigmatism. And Chen et al. In 2010, with 108 subjects, showed a higher prevalence of myopia, hyperopia, and astigmatism in premature infants. And another study showed that there is statistically significant association between anisometropia and amblyopia. So my conclusion is, the premature babies have significantly higher rates of refractive errors and amblyopia, and strabismus is also at a higher rate among these children, and therefore a regular and long-term follow-up of these babies is important for early detection as well as treatment of these ocular problems. And my study was also aimed at highlighting the need for an amblyopia screening in school-going children. The limitation was most of these children included in the study were under our follow-up, so may not be directly applicable to the general population. So these were my references. Thank you.
So how many of your 61 children had ROP?
61% had ROP, sir.
Okay. And how many of them received laser?
Those with type 2 ROP and AP ROP received laser treatment, sir.
So how many among these 61?
Among the 61...
Okay. And how did they compare? Was laser a higher risk?
Actually, I did a statistical analysis, but I couldn't draw any statistical significance between this laser and refractive errors. So.
Okay. Between ROP and premature children without ROP, was there a significant difference?
Sir,
those with ROP versus those without ROP, was there a difference in the refractive error and amblyopia?
Yeah, those with ROP had a higher rate for refractive error as well as amblyopia.
Okay. So that is the message.
Yeah.